I wanted to make a couple of announcements. One of them is that somebody brought to my attention this morning that I had a mix-up on my slides in the psychotic disorders lecture. I don't remember the slide number, but I'm going to update it right after this when I go back to my office. But aripiprazole, brexpiprazole, and cariprazine are D2 partial agonists. The slide that they're on, where it talks about their mechanism of action, says D2 partial antagonists, but they're partial agonists. So there's like a little graph that's on that slide, and it shows like the dose-response effect of what happens with a full agonist and what happens with a partial agonist. And so that dose-response curve still represents what happens with those three medications at the dopamine D2 receptors. So as a first announcement. The second announcement I wanted to cover was quiz 2 results. So there were 2 questions that it seems that some people in the class had a bit difficult time with. The first one was number 3, which was somebody with PTSD who said that while the person is reporting nightmares and jumpiness, the most bothersome symptom is negative mood and guilt and shame and stuff. And so when that happens, because what we do with PTSD, and we talked about this in class, we go after the most the most bothersome symptom first. Why don't we start 2 meds at the exact same time in somebody new? So to see what's effective and side effects. So both of those things. So we want to make sure that if we start something, we get to see some effect from that one thing. And if that thing has side effects, then we know that it's specifically that that's causing it. So we go for just 1 med at a time. And then we go after the person's most bothersome side effects, or I'm sorry, most bothersome symptoms of their illness, right? And so if somebody says, yeah, I have jumpiness and nightmares, but I can't get myself out of bed, I'm plagued by guilt and shame every day, I feel depressed all the time, what do you think you would start? What's that? An antidepressant. Because we really want to get after that cluster, or like the D, criterion D symptoms, to try to improve that person's mood. So it was like half the class said start sertraline and do cognitive processing therapy, and half the class said start prazosin and cognitive processing therapy. But prazosin wouldn't be the most appropriate answer to do right at that very time because the person's most bothersome symptoms were depression. So that's that question. And the next question was question 8, which was somebody with GAD. I can't remember the specifics, but one of the responses were split kind of again almost half and half between starting citalopram because the effect on serotonin will improve the person's mood and anxiety. Maybe it was like anxiety with depression or something. And then another part of the class, so it was somebody who didn't want to start something that was going to cause her to feel drowsy and sleepy and stuff. So then about the other, like maybe third of the class said bupropion because the effects on norepinephrine and dopamine will improve the person's mood. So the thing is that bupropion actually isn't indicated in GAD. And so that's something also that we covered in lecture, and that's definitely pretty clear on the slides that you don't see bupropion anywhere on the GAD material. So so we're going to keep those questions. We're not going to throw out either of those because, first off, half of the class actually got them, and so we wanted to make sure that they get awarded for having the right answers. But also, they're pretty important points, and I want to make sure that you guys remember them. I'll probably try to do some sort of rendition of those kinds of things on the exam just to really reinforce those points. Okay, so any questions? Go ahead. Yeah, sure. So this is something that I'm not going to I'm not going to test you on like what actually happens in those things, but so cognitive processing therapy is like cognitive behavioral therapy. So it's a big focus on the emphasis in people with PTSD is that they have this skewed perception of the world that the world is unsafe. And in cognitive processing therapy, there's a lot of work that's done to change that perception of the world and try to get them to stop those thoughts that aren't very helpful to them and change them into thoughts that will be more productive for them. There's also a huge behavioral component, too, in cognitive processing therapy. I know we talked about in prolonged exposure, where you do certain types of exposures. You make yourself listen or record the memory that you're having a lot, and you'll also like expose yourself to things that you're avoiding. There's an element of that, too, in cognitive processing therapy. So there's a cognitive piece and a behavioral piece. They just call it something different. Interpersonal therapy is more of like the supportive therapy. It's like talk therapy. You go into somebody's office, you lay on the couch, and you tell them how your day went. So there's very little evidence behind interpersonal therapy compared to the other types of therapies. But we always just have them, we list them as like a treatment option because it's something that a lot of people end up getting involved in. But it's not, definitely not the most recommended. Okay? Go for it. Clonazepam? So what kind of medication is clonazepam? What's the class? A benzo, right? So she said she doesn't want anything that's going to slow her down or make her feel drowsy. What do benzos do? They slow you down and they make you feel drowsy. And then if you'll remember, I'm anti-benzo. So I don't care if you guys end up going like on rotations at some point in the future, or you get residencies and you work with people who like love benzos and they prescribe them all the time. That's fine, but just know that like for the purposes of taking my tests, the bad things almost always are benzos, and the good things are almost always non-benzo options. So I'm just gonna like blanket statement that for you because I hate benzos. The other thing I wanted to ask you guys was with the recording from, well, I guess I recorded it yesterday. I was like totally sick and like stuffed up, and all of my M's sounded like B's. And so I didn't want to record on Monday. But did that go okay? And does anybody have any questions on the psychotic disorders material? Are the pre-worksheets going okay? Are they maybe a little bit more straightforward than the depression ones? Because I feel like I haven't gotten as many questions on those. Or have you guys just not gotten like all the way into it yet? Oh, okay. Oh, go ahead. Yeah, sure. And that makes perfect sense to me. So the question was, if you're filling in stuff based on like what, say, Micromedics says, then you're not sure if you're focusing on the right things, and maybe you're filling in something that is totally not what I was looking for in that spot. So if it's really not clear, like if there's any subjectivity to it whatsoever, and you're like, maybe this is the right thing, post it in Blackboard, and I'll just tell you the answer. Like, I just want to make sure like everybody has access to like what my train of thought was when I was writing that stuff up. But and you'll see that like the way that other people posted in Blackboard, they wrote basically the line out and like had the blank spots included, and then I just told them what the answers were. So yeah, just do it that way. I think that's probably the easiest way. Okay, so, and then bipolar disorders is the other one that has pre-lecture worksheets, and then the last lecture for tomorrow doesn't have pre-lecture worksheets. So, we'll jump in. Here's the session ID, which I guess has been up there this whole time. Everybody got it? Okay. Recommended reading is just from DePiro. Lecture objectives for here, so we're going to cover kind of a lot. So, bipolar disorder, this lecture got kind of like all over the place because I didn't want to do, like with depression, I was able to put a lot of stuff in the pre-lecture worksheets because it was just really like black and white stuff about meds. There wasn't a lot of subjectivity to it. Bipolar disorder, it's a little bit different. There's a little bit more interpretation with the medications. So what I tried to do was put in all of the stuff that was really straightforward into the pre-lecture worksheets, and then I included a bunch of other stuff in this lecture. So we'll be covering the last three objectives in this lecture today, but some of them were also covered in the pre-lecture worksheets. Okay, so I have to come over here. So we have the first question. What is Bill's likely diagnosis? He's a 40-year-old male who struggled for the past 20 years with varying moods. He's been psychiatrically hospitalized 11 times in his life. Most occasions were due to him losing touch with reality and staying awake for days to weeks at a time. Some hospitalizations, however, were following suicide attempts in the setting of very low mood. So what's his diagnosis? Bipolar 1, bipolar 2, cyclothymia, bipolar 1 with rapid cycling, or none of the above? Okay. Yep. So most of the class said bipolar 1. For those of you who thought bipolar 2, what makes you think bipolar 2 as opposed to bipolar 1? If you're willing to share. Okay, for people who said bipolar 1, what makes you say bipolar 1 as opposed to bipolar 2? What? He's been hospitalized. So if a person requires hospitalization or has psychosis, which is the losing touch with reality part, that means that it's mania. So if they have mania, they have bipolar 1. That's like the quick and easy way to understand that one. Some portion of people said cyclothymia, and so if you'll remember, cyclothymia is the diagnosis where you've never had full-blown mania, and you also haven't really had many episodes of major depression. You just kind of cycle between hypomania and like mild, maybe some depressive symptoms, over a period of 2 years at least. So this person, since he's had full-blown mania, but also has had hospitalizations following suicide attempts and setting a very low mood, that would also tell us he's had major depressive episodes too. So this person does look like more of a classic bipolar 1 presentation. And then some other people said bipolar 1 with rapid cycling. So we can't actually tell whether or not this is rapid cycling. What's the requirement for rapid cycling? Kind of. That's kind of part of it. What else? It's like a really black and white set of criteria for rapid cycling. 4 episodes in a year. So they've either had four combination of mania and major depression and hypomania within 1 year. Okay. So bipolar 1. All right, question 2, what's Janet's diagnosis? So Janet is a 37-year-old female who has also struggled for 20 years with varying moods. She's been hospitalized 75 times in her life. Some admissions were for various medical complaints like pain or fatigue, while many were for suicidal ideation, and 8 admissions followed suicide attempts. She says she goes from high to low within a matter of minutes. So what does she have? Same options. Okay. So most people say bipolar 1 with rapid cycling. So this is a trick question. So this is actually not bipolar disorder at all. This is a personality disorder. And I'm not going to test you on personality disorders, but what I do want you guys to think about is not every time somebody says they have a bipolar disorder diagnosis or a clinician says that a person has a bipolar disorder diagnosis, does that person actually have a bipolar disorder diagnosis? I see this constantly. Every single day, we have patients on our inpatient list, like on our consult list, and patients that come into our outpatient clinic that say, oh, it's my bipolar, when they've never had a manic episode. They maybe have been depressed, because a lot of times people with personality disorders have depression and struggle a lot with mood states. But this is a personality disorder, and this is not bipolar disorder. So how can we rule out bipolar disorder based on what we have? There's one big thing. There's no mania. Yep. Or hypomania. But I mean the high, go from high to low, I don't know. But go ahead. In a matter of minutes. So that's the big thing. So a lot of times people with personality disorders, specifically borderline personality disorder, will say, one day I'm happy and the next day I'm sad. And that's like a really common thing that they say. That's not bipolar disorder. That's a personality disorder. Because with bipolar disorder, there are certain requirements for duration of time of the different mood states, right? So mania, by definition, lasts how long? At least a week. Hypomania lasts how long? Four days, at least 4 days. Major depression, a major depressive episode lasts at least how long? 2 weeks, exactly. So you don't see that anywhere in here. So typically what happens is somebody says that last line, and I immediately start thinking, this doesn't sound like bipolar disorder. And then I look at all the other stuff, and I'm like, yeah, this is a personality disorder. Because it's very common that people with borderline personality disorder do have tons of hospitalizations for suicide attempts and suicidal ideation. Go ahead. Sure. Sure. Good question. So the reason that we know that this is mania is most occasions where he was losing touch with reality, staying awake for days to weeks at a time. So he was psychotic. That's the losing touch with reality, means he's not based in reality, so that's psychosis. And psychosis mixed with the not sleeping for days to weeks at a time, that's mania. That's just pretty much textbook mania. Is that clear to everybody else? Okay. Okay, so one more diagnosis question. Kayla is a 29-year-old female reporting extremely low mood for the past 3 weeks. She endorses anhedonia, guilt, hopelessness, and increased appetite. She also states that she hasn't slept for the past 4 days and that she's uncomfortably irritable. What is her diagnosis? Okay. Oh boy. All right. Nice. I love when this happens. So, everybody who said bipolar 2, why'd you say bipolar 2? Come on, give me some. For the past 4 days, she's been uncomfortably irritable. And so what is that telling you? Maybe hypomanic. Okay. What about everybody who said cyclothymia? So for anybody who doesn't think it's cyclothymia, why would you say it's not cyclothymia? Because it hasn't, yeah, we don't think, it doesn't look, based on what we have, the information that we have, it doesn't look like it's been for 2 years. So bipolar disorder with mixed features. What do we think about that one? What's the definition of bipolar disorder with mixed features? Give it a shot. That's right. So you have primarily the person is associated with one of the mood states, either depression or hypomania or mania, and then kind of like a milder version of the other mood state combined. So when we look at this description, what do you think about that based on that definition? So we said that she hasn't slept for the past 4 days and she's uncomfortably irritable. That sounds like maybe a little bit of hypomania. But she has extremely low mood for the past 3 weeks. Requirement for major depressive episode is 2 weeks. She endorses anhedonia, guilt, hopelessness, and increased appetite. So she has the 5 criteria needed for a major depressive episode. So actually, this is bipolar disorder with mixed features. For none of the above, can I just, out of curiosity, does anybody want to volunteer what the process was? Mm-hmm. Yeah, I could see the subjectivity there. That could be just maybe just depression. And so I would encourage you guys, there's a video I posted. It's not a very good video. It looks like the girl is acting. I don't know if it's real, but I posted it on YouTube, and she's talking about her mixed state. And it does kind of look like she's really depressed, but she like kind of describes how she's been really irritable and stuff. And that's what we tend to see in mixed states. So people, it's kind of like over time with bipolar disorder, and you guys don't need to remember this, but like over time, people have fewer of the like full-blown manic episodes, but they get more common like really bad like mixed state experiences where they're kind of experiencing both of those things at the same time, and they don't feel good at all. Like whereas mania feels really good to people most of the time. They really love being manic, and people will like try to do things sometimes in order to get manic. However, after like a couple decades of going through that, the body and the mind kind of tire out, and it can't keep up anymore. And so then they end up having more of like this mixed state thing for a long time, like for the next several decades of their life. And it looks more like this. But I could absolutely see where this does also kind of look like a description of just depression. And so I'll refrain from putting a question like this on a quiz or exam. Go for it. What's that? Bipolar 2 with mixed features. Great question. So this could totally be bipolar 1. Oh, so this is one of those, I remember when I thought this, when I was making this question. This is one of those examples of, in psychiatry, we have to remember to pick the best answer that we have of the choices. So this could totally be bipolar 2 with mixed features. But the thing that we know is of these options, I guess maybe if I didn't have none of the above in there, bipolar 1 with mixed features is the only one that actually fits this picture. So if we took out none of the above, then the one that makes the most sense is bipolar 1. Go for it. You can't from this. But what you do know is that she does have mixed features. So we can't say, so because it's like her diagnosis is intended to be like, what's her diagnosis? In bipolar disorder, a lot of times it's what's the diagnosis right now. And so a lot of times if you're diagnosing bipolar 1 like for the first time, you wouldn't say just bipolar 1. It would be like bipolar 1 acute manic episode or bipolar 1 acute major depressive episode. So for this situation, I agree with you that you don't know that she's never had a manic episode or that she's definitely had a manic episode. But of these options, we do know that she has mixed features. And so if it was bipolar 1, we would think that she's only in a state of either mania, hypomania, or major depression.
So we're not always going to be able to meet criteria for these patients. It's going to be kind of like...
No, you will. Like, yeah, no. This is just for the purposes of a question. But like when you actually meet patients, you get their full history. So like if she presented to the emergency department, you'd say, when's the last time you've gone more than a week without sleep? And then like they would tell you all about it and tell you all the things that they did during that time. And then that's when you say, okay, this person's definitely had a manic episode before. Right, so that's what I was just saying. So this is one of those examples where of the options that we have, right, there's a best answer. Okay? Right, so that's what I said. If we took out none of the above, then the answer is definitely D. Because, right, it could be bipolar 2. But the thing to remember is, like, it could be either or. Bipolar 1 or bipolar 2 based on the information that we have. Okay? Mm-hmm. I would try to make it extremely clear, and if it's not clear, I will throw the question out, for sure. I would never keep this question on a quiz based on this really awesome discussion that we've just had. There we go. See, could also be bipolar too. I remembered. Okay. Which meds can induce mania? We have diuretics, SSRIs, steroids, thiazolidine diones, benzodiazepines, amphetamines, and levothyroxine, and then a combination of which of those? All right, so most of you guys said C, because I don't remember. Yep. Okay, so SSRIs, steroids, amphetamines, and levothyroxine. It's like levothyroxine if you're taking too much, that can induce a manic state. Diuretics can't, they're not associated with inducing mania. Thiazolidine diones are used in what? Diabetes, those are not associated with mania. And benzos are actually given to treat mania in acute manic episodes to make people sleep. So those are also not known for inducing mania. All right, what is the target serum lithium concentration for acute mania? 0.6 to 1.2, 0.5 to 1.0, 0.7 to 1.4, 0.8 to 1.5. Okay. Ooh. Okay, so you guys remember, is there a difference between treating acute mania and maintenance? Anybody remember that part? So with acute mania, it's more of a severe situation, and we need to try to kind of get a bigger bang for our buck. And so we actually do target 0.8 to 1.5, as opposed to 0.6 to 1.2. 0.6 to 1.2 is the normal, it's the target range for maintenance. Now you can see that they kind of overlap a little bit. It's just that if somebody gets up to 0.6, then we're going to probably increase their dose as we're starting lithium if they're acutely manic. Okay? Which of the following mood stabilizing agents interacts so much with valproic acid that its dose must be adjusted if it is given with that agent? Is it lamotrigine, lithium, carbamazepine, or quetiapine? Okay. Oh boy. Okay, thoughts on this one? People who said, let's see, people who said carbamazepine. What do you remember about that one? Oh, go for it. Yeah, there's a line on the carbamazepine slide that says many drug interactions. So that makes sense to me why most of you would end up saying that based on that line. But there's a whole other separate set of information, I think a whole slide dedicated to this, I want to say, where actually lamotrigine and valproic acid interact so much that we have to adjust the doses of both of them. So, or rather, we have to adjust the dose of lamotrigine in order to get it started if we're combining agents. Because what happens a lot in bipolar disorder is that we do end up combining agents if we're finding that we're having a tough time controlling all of the different mood states. Any questions about this? Was there anything that seemed to be conflicting based on the pre-lecture stuff? Okay. All right, which of the following are potential adverse effects of carbamazepine? Is it blurred vision, hyponatremia, akathisia, Stevens-Johnson's? agranulocytosis, or pseudoparkinsonism, and the combination of those. Okay. Oh boy. All right, so we're just gonna go. So with carbamazepine, there are a few like pretty common symptoms that we look out for and ones that we get really worried about. So those tend to be, blurred vision tends to be a little bit more common in hyponatremia. But then we also need to monitor for Stevens-Johnson's syndrome, which is a really big possibility with carbamazepine. It's an even bigger possibility with lamotrigine. That's like the big black box warning with lamotrigine, and it's the reason why we have to start at a really low dose. And then also you can get neutropenia and agranulocytosis with carbamazepine. Also, I realized I had a couple questions like this. I don't put questions like this on quizzes and tests. If anything, I would just put like lists of adverse effects and have you guys pick from the answer. I don't have you like trying to combine and figure out which answer has all of the right ones in it. This is just for the purposes of lecture. Okay, so patient case. So Sarah is a 24-year-old female with no prior medical or psychiatric problems. She presents to MGH emergency department brought in by police after setting fire to her living room rug on her front porch. This is a real case that happened when I was at Michigan. So I was like, oh my God, I can't believe this really happens. In the emergency department, Sarah explains God told her that the living room rug was evil and that she had to cleanse her house of it by setting it on fire. She speaks rapidly and quickly switches from one subject to the next. Her boyfriend is at her bedside. He states that Sarah has been acting increasingly odd over the past 1 to 2 weeks. The only change the boyfriend can think of is that she started tanning at a salon 2 weeks ago to get ready for her friend's wedding. Starting about 10 days ago, she hasn't slept more than 1 to 2 hours a night. Several days ago, she started planning her friend's wedding. Boyfriend states her friend did not ask her to do this. She's been spending many hours every day on this project, as well as purchasing many items she can't afford as decorations for the wedding. Her social history includes she drinks, probably a little bit milder than an average college student. She denies all other use of other substances, has 2 to 3 cups of coffee per day, never smoked. Her mother has bipolar affective disorder, and she's deceased by suicide. Her father has no history of mental illness. He's alive and well. For meds, she takes ibuprofen if needed for a headache and loratadine every day for allergies. So, what symptoms is Sarah experiencing that seem to meet criteria for a manic episode? So if we go back and we see that these are the things that probably kind of like piqued all of your guys' ears. So setting fire to her living room furniture because God told her, what would we call that? What? A hallucination, right? An auditory hallucination. She's speaking rapidly and quickly switching from one subject to the next. We just call that rapid speech. She's been acting increasingly odd over the past 1 to 2 weeks, so that's telling us about the duration of time that this has been going on. She hasn't slept more than 1 to 2 hours a night, so we know that that's definitely and it's been for about 10 days, so this is definitely looking like a certain mood state. She started planning her friend's wedding even though her friend didn't ask her to do this, so this is, what is that called? Goal-oriented activity, exactly. And then purchasing many items that she can't afford, where would we classify that under? What's that? Risky behavior, yeah. Okay, so what would we, so this is the kind of case I would give you if I was going to actually ask you to diagnose somebody. So to try to make it like really obvious. But if you guys give me a lot of options, then maybe it's not as obvious as I think it is. But what would you guys diagnose this person with, based on what we have here? Like, what is her episode, would you say? mania, right? Does anybody think that there's anything about this that says hypomania or depression? Okay, so that's clear. So this is the kind of case I would give you on a test to say, like, what do you think is going on here? And then I would probably just say acute manic episode as the option. Okay. So treatment approach. So target symptoms for bipolar disorder are pretty vast. So we go for mood. We're trying to address several different things depending on what the person's actual mood state is. So are they depressed? Are they way too high? Are they manic, so they're elated or euphoric? Are they particularly irritable or hostile? Or do they have mood oh, go for it. Yeah. Yeah, it probably was. That doesn't mean, so this is where, and I think I said this in the pre-lecture material, if it's induced by light, it doesn't mean that it's because of that, and that if she had never, ever been exposed to light, she would never have a manic episode. It's more like that's kind of the trigger that started it. So sometimes we'll start an antidepressant in somebody, and the antidepressant will switch somebody into mania. That doesn't mean that if we, so there's a few things that we do then. We stop the antidepressant. If the mania goes away, then there's this question of, do they actually have bipolar disorder? Maybe it was just the antidepressant. You try a different antidepressant and see what happens. Or you try mood stabilizer. It really depends on how severe the mania got. If the person's mania doesn't go away, this is what we usually use as our test whether or not they have bipolar disorder. If it's substance-induced and the substance is cleared from the body, but the mania is still there, or the mood state specifically is still there, then even though it was induced by that substance, the person still has bipolar disorder. It's just that that was the trigger for it to actually switch. Does that make sense? Okay. All right. So there's also there's cognitive and perceptual symptoms, of course. If somebody's hallucinating, like the person thinking that she's hearing God telling her to do things, we want to get after all of those things. And then certain types of behaviors, like if they're not sleeping, if they're really aggressive, all of the sorts of risky behaviors that we were talking about. We'll go after those. So this is kind of getting at what we were just talking about. You want to make sure that you're evaluating any secondary causes for a mood episode. So this is kind of going after the differential diagnosis and ruling out certain things. Medications are like psychotic disorders for bipolar disorder, it's similar to psychotic disorders where medications are required in order to keep somebody stable. This is one of those, it's a lifelong illness, and even if somebody's symptoms go into remission, we still need to keep them on medications to prevent them from having another episode. Why do you think the reason for that is? Why do we feel like it's so important to prevent them from having another episode? It's dangerous. Mania is a medical emergency. So, because you don't know what they're going to do, and they don't know what they're going to do. And they can be an absolute threat to themselves or other people, and so we have to lock that down and not let it come out again. So, in acute management, specifically with mania or severe major depressive episode, it does usually require hospitalization. We'll often use some sort of mood stabilizer, so that's the lithium, the carbamazepine, the valproic acid, or the lamotrigine, plus another agent. This is in the acute state. So sometimes we'll also use, we oftentimes also use antipsychotics as mood stabilizers. Oftentimes nowadays, it's more common recently to start people on antipsychotics to keep them, or to maintain them. Whereas maybe 10 years ago, they used to mostly do just the mood stabilizers. And that's basically like a risk-benefit. There's side effects and all of that stuff that goes along with all of the options. And so you just kind of pick whatever you feel most comfortable with. So you may combine it with an antipsychotic, especially if somebody's actually psychotic. We want to get after that antipsychotic effect. But then also, we oftentimes will combine it with benzodiazepines if they're acutely manic because they're not sleeping and we need to get them to sleep. Because once you start regulating their sleep patterns, their mania starts to slow down a bit, and they start to kind of get back to normal. So, People are often in the hospital for kind of a while, especially if they're acutely manic, because the mood stabilizers do take a while to get active in the system. And definitely want to ensure that you've had an adequate dose and duration of the trial before trying to assess a certain treatment response. And that looks like somewhere between like 10 days to 2 weeks if somebody's in like an acute episode. So treatment goals for acute mania. You want to rapidly control any sort of agitation or aggression or hostility or impulsivity that they may be experiencing. Return the patient to usual levels of psychosocial functioning. You also want to try to select pharmacotherapy considering patient-specific information. So, for people with acute mania, we have found that valproic acid, which is also called valproate, which is also called divalproex, and its brand name is Depakote, and that's what almost everybody refers to it as when you're like in a hospital setting. That one's probably used one of the most often or common agents, in addition to antipsychotics, especially for acute mania. And then you'll also see, like I said, benzodiazepines for the short term to try to just get the person to sleep. You could use lithium and carbamazepine. Carbamazepine is more of like a second line, and then oxcarbazepine is like third line. I hardly ever see people on oxcarb. Lithium is commonly used. It's just that because the other ones are faster acting, people tend to go to those first. Again, with the whole people trying to get, or like hospital managers and stuff like that, trying to get people out of the hospital sooner. We're trying to go after everything that acts faster, and we don't really want to wait around to wait for medications to start working. That being said, it doesn't mean that lithium is necessarily worse of an agent at managing mania. It's just that it takes a little bit longer. So for patients that have more of like maybe mild symptoms, you could try monotherapy. So try just lithium, just valproate, or just a second-generation antipsychotic. But you'll also, because it's acute mania, you'll want to use some sort of adjunctive therapy, so that's like benzodiazepines to help people sleep. Okay, so in acute major depressive episodes, treatment goals here are to just try to receive symptom remission. You want to return the patient also to usual psychosocial functioning and avoid precipitating a manic or hypomanic episode. Because if you remember from the pre-lecture material, if we just slap on an antidepressant, we could actually induce a manic switch, and that doesn't do good for anybody. So we need to get them to improve their mood without causing them to switch into mania or hypomania. So again, you'll want to select the pharmacotherapy considering patient-specific information. And the options are, in acute major depressive episode, lithium, lamotrigine, some sort of second-generation antipsychotic. The ones that I think have FDA-approved indications in bipolar disorder are lorazepam, and then it's a combination product of olanzapine plus fluoxetine. And I know this is confusing because that's an SSRI, and we know SSRIs can induce manic switches. However, the randomized controlled trial that they did to assess that medication showed that nobody was more at risk of switching into mania when they were on that medication combined with olanzapine. So that's why it's approved. You could consider combining antidepressants, but this is not ever to be used as monotherapy. If you combine an antidepressant with one of the mood stabilizers, and I think that ends up being what happens with the olanzapine plus fluoxetine combination, you can get some mood benefit without causing the manic switch. Does that make sense? Okay. So, for a severe major depressive episode, one of the most common things to do is do lithium with or without an antidepressant. But there isn't really great data supporting that. It's pretty much just like anecdotal data of it tends to be what people just do, they're most comfortable with, they've seen the most success with. For a mild to moderate major depressive episode, you could consider monotherapy with lithium or lamotrigine. And just remember, antidepressant monotherapy is never recommended. Treatment selection depends on the severity of the illness and the associated features. Like, is the person rapidly cycling? Do they have active psychosis? Or does the person actually prefer one thing or another? You could consider electroconvulsive therapy for patients who are in acute states of suicidality or psychosis, or if they have severe depression as part of their bipolar disorder in the setting of pregnancy, because mood stabilizers, all of them are teratogenic, and so the safest option is actually ECT. Okay, so rapid cycling, we know that that's at least 4 mood episodes in a year. In these cases, you want to identify and treat any medical conditions that could be contributing. So what happens a lot of times is we know people with psychiatric illnesses can have, or maybe at higher risk of having other types of comorbidities. And if those comorbidities aren't under good control, they can be contributing to people feeling worse and having maybe more mood episodes. So if we make sure that the person's kind of all patched up and in good shape from all of their comorbidities, then that gives us a better idea of what we're actually looking at, what we're actually treating, and might make it easier for us to treat the actual psychiatric diagnosis. So you want to taper off any meds that might be contributing to the rapid cycling. So this is cycling between usually manic and depressed states. And so if the person's on antidepressants, maybe those antidepressants are causing the manic switches. For initial treatment, you oftentimes will include lithium and valproate, so a combination. There is some data that says that valproate might be better for mixed states and rapid cycling, and I think I have it on another slide as to why that is, but it's because it has some of those anti-kindling properties. And basically, just as the bullet above it says, medication combinations are often required if somebody's in a rapid cycling situation. So, patient case, we have Ian. He's a 22-year-old male presenting to the emergency department. Ian hasn't slept more than 30 minutes in a 24-hour period for the past 9 days. He hasn't gone to class in a week because he started working on something, quote, much more important. He speaks quickly and is impossible to interrupt. He's a college student and he's supposed to graduate this spring. What else would you like to know about Ian before formulating your assessment and recommending treatment? What was that? Has this happened before? Definitely. What else? Is it substance-induced? Absolutely. What else? What else does he have going on? Yeah, any comorbidities? What else? Other medications? Mm-hmm. Anything else? Okay. So, what other symptoms is he having right now? That's important for us to kind of have an idea. Is he also having any depressed symptoms? Maybe he's in a mixed state. So we really want to make sure we have a very good description of what he's actually experiencing right now. Like we said, any substance use. Are all of his medical tests negative? So that was like we were ruling out other medical conditions. Has he been using any light therapy that maybe could have caused this manic switch? Or has he recently started ECT, because ECT can also cause a manic switch? So we're basically just trying to rule out all of the causes that could be contributing, as well as trying to find out more about his current situation. So he ends up being diagnosed with bipolar I disorder, and he's having an acute manic episode. What would you recommend the treatment team start immediately? Lorazepam, olanzapine, lamotrigine, or fluoxetine? Okay. Okay, so this is well, before you do that. So for everybody who said lamotrigine, which is the majority of you, tell me why. (42% said lamotrigine. Tell me why. Oh, I'll wait. Because it's a mood stabilizer? Okay. Anything else? Any other ideas? I'm sorry? They just answered towards C in a while? Sure. Okay. So what about people who said lorazepam, or, well, what about people who said lorazepam? Yep, he's in a manic state. We got to get him to sleep. What about people who said olanzapine? What's that? It's fast acting. It's an antipsychotic. So this is another trick question. There are two answers. Lorazepam and olanzapine. So lamotrigine is a mood stabilizer, yes. But the pre-lecture material highlights, and I'll highlight it again here, takes forever to start working. Like 2 months before we get to an effective dose. So we never, ever start lamotrigine in people that are acutely manic. Also, because it's not very good for bipolar 1, the evidence does not support its use in bipolar 1, and its use is only supported by evidence in bipolar 2 disorder. So it tends to be best at preventing hypomanic episodes as well as major depressive episodes, but it's not very good at preventing mania. Oops. Okay. So, on to maintenance. So we've covered acute. So treatment goals for maintenance. We want to prevent relapse because it's dangerous if somebody has a relapse. We want to reduce subthreshold symptoms, suicide risk, and cycling frequency. So what that means is like maybe they're not hypomanic, but they're like kind of getting there. Or maybe they're not really depressed, but they're kind of getting there. We want to really reduce that. We want to get them back to what we call euthymia, which is just normal. We want to reduce suicide risk, of course, because we want to prevent people from committing suicide. And then cycling frequency between mood states. We also want to achieve milder degrees of mood instability. So a lot of times, this is kind of what I was talking about before, where over the course of a person's life with bipolar disorder, in the beginning, they may have these really intense episodes of mania, really intense episodes of depression, and once we start treating it, we can start to reduce the intensity of those. And ideally, we want to prevent people from having those really intense episodes again, but that's only really possible with pharmacotherapy. And then, of course, we want to improve overall functioning. The guidelines do recommend continuing meds that were used to achieve remission. So if somebody was admitted to the hospital, treated with olanzapine and lorazepam, we'd stop lorazepam after they start sleeping and doing well there. But if olanzapine was the thing that helps them get out of the acute manic state, you just continue olanzapine. You discharge them, and you continue olanzapine at the same dose that worked for their acute mania. So you want to pick your med based on the predominant pole. So are they more manic or are they more depressed? If they're more manic, you see that there's some overlap here, but for the most part, you could choose lithium in either situation. But if you'll remember, lithium's not as fast acting in mania as these other options. So valproate, second-generation antipsychotics, and carbamazepine are also options in mania. And then with depression, while lithium's also an option, you could consider lamotrigine, but you wouldn't do lamotrigine if the person definitely has had a manic state before, because it means they have bipolar 1. And so we know lamotrigine is not a good option for bipolar 1. You could consider a second-generation antipsychotic. Lurazidone's highlighted here because it has an FDA-approved indication for this situation, for depression in bipolar disorder. And then valproate is also an option for depression. So lithium and valproate can be used for either, and antipsychotics. So treatment selection depends on the type of the most recent mood episode. So really manic or depressed, that's like picking based on the poll. Illness severity, associated features, whether or not they have rapid cycling, mixed features, psychosis, and patient preference. So considering antipsychotics, also very often it's common for people to, person comes in, they're acutely manic, they get into the emergency department, and you give them a bunch of benzos, and then you also give them some haloperidol, or maybe a little fluphenazine. So you're giving them first-generation antipsychotics, which we know kind of like zonk people out. They definitely go after any sort of psychotic symptoms pretty quickly, and they make them really tired, and that's what we're going after. But we don't like to continue people on first-generation antipsychotics for a lot of the reasons that I talked about in the psychosis lecture. So what we like to do is maybe they get started on a little bit of haloperidol when they're first admitted. You just kind of stop that pretty quickly, start a second generation, or start a mood stabilizer, and let them go with the second generation agent or the mood stabilizer. You don't continue first generation antipsychotics for the most part. For non-pharmacotherapy options, they're used, sort of. Like you can, because a lot of times, especially with people who are experiencing certain like depressive episodes and you want to try to help them kind of snap out of the depression, it's different with bipolar disorder. And it's not easy to snap out of it with major depressive disorder, but there are different things that people can do behaviorally and cognitively to try to get them thinking differently about their certain state. Whereas with bipolar disorder, there's a bit more biology that's involved, that's happening with the chemicals in the brain and all of that stuff. That being said, you can still combine some sort of cognitive behavioral therapy with people who have bipolar disorder. It's just that meds are needed. Sometimes with depression, we can get away with just therapy. With bipolar disorder, we can't get away with just therapy, and we have to use meds. So what happens if somebody's on a medication and they've been stable on it, and then they have breakthrough symptoms? What do we think about? Well, if they're manic, we need to check their drug levels to make sure that they're actually at the therapeutic levels to prevent manic episodes. Might need to start an antipsychotic agent. Maybe they're only on lithium, and maybe the drug level's fine, but now they're starting to hear voices. Well, then we probably need to start an antipsychotic. If somebody's severely agitated or really isn't sleeping and they're stable on a mood stabilizer, it might be time to also reintroduce a benzodiazepine for a short period of time. If somebody's depressed, having breakthrough depression symptoms, again, check serum drug levels, and then always take caution if you're considering adding an antidepressant, because you could switch them into mania. So if somebody's admitted to the hospital and they've been there for like 2 weeks and their symptoms of mania are just not resolving, a couple other things you can do. Combine agents, so add another first-line agent. So maybe you started them on lithium and their symptoms are still there. Maybe you add a second-generation antipsychotic, or vice versa, however that worked out. You could also add some of the second or third-line agents, like carbamazepine or oxcarbazepine. If psychosis is present, definitely add an antipsychotic. The other things you could consider if things are really severe, especially if somebody is having symptoms of suicidality, is considering ECT for people who are treatment resistant. And the other thing you could do is if ECT doesn't work, everything else isn't working, there are people with bipolar disorder who are on clozapine as lifelong therapy. For unresponsive depressive symptoms, again, want to make sure doses are optimized, check drug levels if you can. Consider adding lamotrigine or bupropion. Now you guys are all like, wait, you just told me that I can't add antidepressants because they're going to cause somebody to switch into mania. There's a pretty clear association with serotonin and manic switches. What we know about bupropion is it affects what neurotransmitters? Norepinephrine and dopamine. It doesn't affect serotonin. So bupropion, even though it's what we call an activating antidepressant, it's actually the one that's least associated with switching to manic episodes. So that tends to be the one that most people think of first when they're considering adding on an antidepressant in somebody who's having a depressed episode but has a diagnosis of bipolar disorder. So, like I said, all of the other agents, because they affect serotonin in some way or another, they have that risk of causing a manic switch. Always remember, psychotic features require an antipsychotic, and then you could consider ECT for severely treatment-resistant patients. So, things to consider if somebody is in a state of acute bipolar depression. You want to weigh the risks and benefits between starting an antidepressant. Maybe it's totally safe, and maybe that's completely fine to start an antidepressant in them, and they're probably not going to switch into mania. But you really want to make sure that they're not going to switch into mania before you add that antidepressant. So you just want to kind of weigh those risks. Do we know whether or not antidepressants actually offer true benefits? So I told you guys, I think in the depression lecture, maybe, but we want to make sure that we have the diagnosis right. So if somebody presents with depression and they actually have bipolar disorder and we give them an antidepressant, what we know is that typically the depression does not resolve with the antidepressant in people who actually have bipolar disorder, and that their mood actually gets better if we just get them on a mood stabilizer instead of an antidepressant. So in bipolar disorder, we aren't really sure There isn't good data at all to tell us whether or not if we start an antidepressant, their mood's going to get better. But we do have the data that says if you start an antidepressant, you could switch into mania, and that's a medical emergency where bad things can happen. So you really want to mitigate those risks. Like I just said, bupropion has the lowest risk of causing the manic switch, so if you're considering an antidepressant, consider that one. Depressive episodes take quite a while to resolve. So mania can resolve in like a matter of like 1 or 2 weeks, but depressive episodes can take 6 to 8 weeks. And so it's really like frequent follow-up visits with the patient, making sure that everything's okay, that you're minimizing their access to potentially we're minimizing access to means of suicide. So making sure that they really don't have the ability to commit suicide if they start thinking that way. You really want to like have a close eye on them throughout this time, because they'll maybe be hospitalized for 1 or 2 weeks of this, but eventually they're going to go home. But their depression symptoms are still going to be around for a little while. And so you really want to make sure that you're really minimizing all the risks that are kind of at hand for them. We see, so again, this is the whole anti-suicidal properties with lithium. The data tells us that we see fewer completed and fewer attempted suicides when people are on continued lithium treatment. So even though lithium isn't as effective or isn't as fast-acting in acute mania, we still love lithium because it's anti-suicidal, and people with bipolar disorder have a high suicide risk, up to like 20%. So if we can prevent that from happening, we really want to prevent that from happening. Yes, so you definitely can. The thing is, with clozapine, you want to kind of see a little bit more failure of a bit more things. It's not quite the same as in like schizophrenia or schizoaffective disorder, where if they failed 2 antipsychotics, or if they failed 1 and they're suicidal, just go to clozapine. This is like, maybe they failed lithium, like they're still suicidal on lithium, and they failed maybe a couple other options, maybe a couple other antipsychotic agents, then go to clozapine. It just takes a little bit more to kind of pull that trigger. I'm not going to take a break today because I think I'm going over on time, so I'm going to try to just power through. Hope that's okay. So like I said, with non-pharm treatment, this is almost all of this, like the psycho-ed stuff is just for your information. Remember that bipolar disorder should never be managed without any medications. But you could consider electroconvulsive therapy. Some people are on maintenance ECT, like for the rest of their lives. They'll get an ECT treatment like once a week or once every other week, especially for people who have severe and recurrent mood disorders. And then always remember that it could be used safely in pregnancy. So another patient case. Now we have Fiona. She's a 51-year-old female with bipolar I disorder. She has not had a full-blown manic episode in over a decade. She's been struggling with a major depressive episode for the past 7 months, though. Her psychiatrist has made a few med changes, but her symptoms persist. She's currently taking risperidone 6 milligrams at bedtime. Which of the following medication changes is most appropriate? Would you taper off the risperidone and start venlafaxine? Would you taper off risperidone and start oxcarbazepine? Would you continue risperidone and add bupropion? Or would you continue risperidone and add buspirone? Okay. All right. Nice. I love when 100% of the class gets the answer I was thinking of. So, venlafaxine is a what? What kind of medication is this? SNRI, so that could cause a manic switch. Oxcarbazepine is like third line, and like I said, we hardly ever use it. What's buspirone? What's that? It's for anxiety, right? So it's actually an anxiolytic, and so that wouldn't do anything. Bupropion's the one that's least likely to cause a manic switch, so it makes sense that we could try that for her. Okay, so quick run through of some of the different pharmacotherapy options. In general, for treatment duration, we see that length of treatment varies, but that's just because people just stop taking their meds when they think they get better. Ideally, people are on medications for the rest of their lives. We see that the relapse risk is definitely high without pharmacotherapy. So we'll first talk a bit about lithium. Lithium is FDA approved for the treatment of bipolar affective disorder in states of acute mania, mixed episodes, and for maintenance treatment. It also has off-label use for bipolar disorder in acute depression or depression with suicidality or impulsivity. So one of the other things that we see with, we'll start sometimes people on lithium who have like really struggling with impulsive behaviors, totally unrelated to like bipolar disorder or anything. Like maybe they have anxiety or depression or something and they're really struggling with impulsivity. A lot of times that impulsivity comes out in suicidal behavior, and so we really don't want to risk that, and so that's when we start considering lithium. So we see that lithium tends to be really useful in people who have this like classic bipolar disorder presentation, which is that they have these very distinct mood episodes and then they have periods of mood remission. So they go through a depressed state or major depressive episode and then they get better and they're euthymic. And then maybe a year later they have a manic episode and then that gets better and then they're euthymic again. And that kind of goes back and forth. We tend to see the classic bipolar disorder is where you have a you have a manic episode and then pretty quickly following you get a depressive episode. And that kind of makes sense if you think about like probably how hard the body and the brain are working during mania. That once that slows down, your body and your brain are just like, I give up. Like, I don't want to do this anymore. And it makes sense that you would then feel pretty depressed after that. So people who have a family history of bipolar affective disorder tend to be more of that like classic bipolar. And then people who don't have or have very few comorbidities, and that's because lithium has lots of drug interactions, and so and can cause other comorbidities if they're not controlled well. So you want to make sure that for the most part people are otherwise pretty healthy. Like we talked about, lithium is not as effective in rapid cycling or mixed states as some of the other options like valproic acid or carbamazepine or antipsychotics. And like I said, the data shows it does decrease suicidality. Mechanism of action is totally FYI because we don't really know how it works, but it does these things, and maybe these things affect the ability for it to be able to stabilize mood. For therapeutic drug monitoring, we really want to prevent lithium toxicity because people can die. We have to check levels every time you start it, and then every time you have a dose change. It takes about 5 days to see the effect of the dose change, so you'll wait 4 to 5 days, check a level, and then see what happens. Even in stable patients who've had stable levels for the last 10 years, you still want to check levels every 6 months just to make sure things stay stable. What we do see is that lithium is associated with a concentration-dependent toxicity. And so what happens is that with mild toxicity, which is about 1.5 to 2 milliequivalents per liter. So if you remember, treating acute mania was 0.8 to 1.5. So we're getting into that, like the higher end of that range is almost approaching toxicity, and so you really want to be monitoring for side effects when people get started on lithium if you're actually targeting the higher end of that dosing range or serum level. So you'll see things like nausea, vomiting, blurred vision, maybe difficulty with balance, overall lethargy, and you do see hand tremor. So sometimes when people start lithium, just as a side effect of lithium, there's like a fine tremor a little bit. And I've definitely seen this in like several patients, so it's pretty common. If it's really bothersome to them, but the lithium's really working for them, you can add on like propranolol or something to try to get after that. But once you start seeing a coarse hand tremor, so like really like a lot of movement happening, then it's actually showing more signs of like toxicity instead of just a side effect. So you want to keep a lookout for that. Moderate toxicity is between 2 and 2.5 milliequivalents per liter, and you start seeing like slurred speech and confusion. So people like are starting to get a little bit delirious and they're having a tough time just like maintaining their mental status. And then severe toxicity is over 2.5, and at this point you're seeing a whole bunch of things go wrong. seizures, arrhythmias, stupor, coma, high mortality risk. One of the reasons, if you see, like a lot of these things, seizures and arrhythmias, it's like, well, that's funny because you could see that with electrolyte abnormalities. And the thing with lithium is that it's an ion, so it's lithium plus 1. It looks a lot like sodium to the body. So if you think, like if you go to, I've seen this before, where people have like lithium salt, or they used to use lithium salt instead of like potassium salt for like low sodium diets, which is funny. Like I wonder if those people were all like totally not suicidal because they had those anti-suicidal properties. But the body kind of looks at lithium like it's sodium. And so it causes a whole bunch of weird abnormalities in like the way you clear fluids. It changes like the way like it's cleared through the kidneys, and it kind of can like affect the way that the body clears sodium because the body's kind of confusing it for sodium because it's that 1+ ion. So when you see things like seizures and arrhythmias, that kind of makes sense. If the body has this like skewed perception of like, I think my sodium's off, and now my heartbeat's changing, and now my action potentials are changing because the sodium levels are off. So if somebody has lithium toxicity, you have to stop lithium, like immediately. Remove any unabsorbed drug, if possible, via oral lavage, basically making them throw up. Correct any fluid electrolyte abnormalities, because it's likely that there are some, like I said, because the body's confusing it for sodium. Your sodium's probably going to be off. Of course, any supportive care needed, and dialysis if there's very severe cases. So other things to worry about are drug-drug interactions with lithium. We do see that lithium does interact with lots of other medications. So carbamazepine, diltiazem, phenothiazines, phenytoin, tricyclics, verapamil, haloperidol, all of these agents can increase the neurotoxicity risk of lithium. So that's like increasing seizure risk and causing confusion and those things. ACE inhibitors and ARBs, so anything that affects the kidneys in any way will interact with lithium. So ACE inhibitors and ARBs, because they decrease sodium concentration from the renin-angiotensin-aldosterone system interruption, they actually increase the risk of lithium toxicity because the body's like basically wasting sodium and then trying to hold on to everything else that's 1+, and so it's holding on to lithium and it's not clearing it. NSAIDs, because they decrease renal lithium clearance, they also increase the risk of lithium toxicity. Methylxanthines, those are like caffeine, theophylline, those things. Osmotic diuretics and bicarbonate decrease serum lithium concentrations. And then thiazide diuretics, because they decrease sodium concentration, kind of the same thing like ACE inhibitors and ARBs, because your body's getting rid of sodium. It starts holding on to the lithium and not clearing it, so that increases risk for lithium toxicity. So up to 3/4 of patients that are on lithium will experience lithium adverse effects. Most patients believe that the benefits outweigh the adverse effects, and so they're willing to deal with it. Like I said, the people that I've seen that have the fine hand tremor, they're like, whatever, I don't want to kill myself anymore, so this is awesome. The peak effects, so sometimes if you'll take a dose, you'll have like a peak effect, and it'll cause people to feel maybe a little bit confused or maybe more slowed down and more tired. If you switch from the immediate release formulation to the extended release formulation, even though it's extended release, it's still dosed sometimes multiple times a day. But that tends to make the peak happen a little bit less intensely. And then you could try to consolidate the entire dose and move it to bedtime. I'm not going to go through these adverse effects. You can kind of read through the list on your own. But these are all common within the therapeutic range. So at safe lithium levels, people are still experiencing a lot of these symptoms. After more than about 10 years of treatment, it is possible for people to have morphological changes in the kidneys. So because it's cleared so completely, it's cleared 100% through the kidneys, it could start to affect the kidneys' function. And so you'll always want to be monitoring renal function as long as people are on lithium. So for patient counseling, it can be taken with or without food. Of course, if it's an extended release product, swallow it whole, don't crush it up. Avoid changes in dietary sodium. So this is another thing to remember. So if you I don't know, if you all of a sudden get diagnosed with high blood pressure and your doctor tells you to go on the DASH diet and you've been somebody who's eating like McDonald's and Chinese food like every single day, that's going to be a massive change in your sodium intake, and that will affect your lithium levels. So you really want to work closely with your PCP who told you to change your diet and your psychiatrist who's prescribing your lithium to make sure that you still have safe levels of lithium in your body while you do this. Avoid excessive caffeine, because that's one of those methylxanthines that's going to clear lithium more fully. Or if you just kind of stay at a constant level of caffeine. So this is kind of like warfarin, like where you like always want to have about the same amount of lettuce every day or the same amount of vitamin K every day. So with lithium, you kind of always want to have about the same amount of sodium and the same amount of caffeine every day. So if you're not used to having any caffeine, don't start. If you're used to having a couple cups a day, just stay with a couple cups a day and let your doctor adjust your lithium dose to make sure that your levels stay within the therapeutic range. Avoid becoming dehydrated, because this will affect your electrolytes. So this is a big thing we do a lot with patients, especially when they're just getting started with lithium in the hospital. We're like following them around with water cups, saying like, drink more water, you need to drink more water, because it can also cause them to be toxic. Always review common adverse effects that they should be looking out for, and they should call you if they start experiencing. And then review the importance of routine drug level monitoring so they know that they need to come in for appointments and lab checkups. So another case. Juan is being seen by the on-call pharmacist in the emergency department. He is brought in by police after they got a call from a neighbor reporting smoke coming from Juan's apartment. They found small piles of burning paper in the kitchen, and when Juan is asked about it, he says, quote, "I was working on my project. You wouldn't understand." He also refers to conversations he was having with a female friend in his apartment, although police report no one else was there. During the interview, Juan becomes very agitated and asks the psychiatrist to leave because he believes she is someone he has met before and he doesn't like. He is not agreeable to hospitalization. Upon chart review, you see that Juan has a diagnosis of bipolar 1 disorder. He has been lost to follow-up for the past several months. So what other information do you want? Medication list? Absolutely. What else? Kind of the same stuff that we talked about in that other case. What's that? If there's any substances contributing. What else? Any other comorbidities that could be causing some of the symptoms to be worse? What else? Has he been hospitalized before? What other symptoms is he having right now? Yep. Okay. So, what medications is he on? Has he started any new medications recently? Those kind of go hand in hand. Other psychiatric medications that he's tried. So how long has he been like this? That kind of gets after his current symptoms. And is he having any thoughts of hurting himself or someone else? Okay, valproic acid. So, like I said, valproic acid has a lot of different names. A lot of times it's abbreviated as VPA or DVA because of the divalproics. We hardly ever use valproic acid in its form, valproic acid. That is a drug formulation that is available. However, it tends to have a lot more side effects, a lot of nausea, a lot more sedation. And so we usually, almost always, will go with divalproex, which is the one that has the brand name of Depakote. FDA-approved indications include bipolar disorder during an acute manic or mixed episode with or without psychosis. Valproic acid is also used for people who have migraines to prevent migraines from happening, and is absolutely a seizure, an anti-epileptic medication that's used for seizure prophylaxis. Valproic acid can also be helpful for people who, in addition to their bipolar disorder, have panic disorder or maybe a substance use disorder with neuropathy, because it can help with neuropathic pain symptoms. So most of the valproic acid mechanism of action stuff is also for your information. The way that it works for bipolar disorder isn't fully understood. However, the thing to remember is that the theory behind its use is that it does have these anti-kindling properties. And so with bipolar disorder, if people go untreated, we expect to see that their mood episodes get more severe and more frequent over time. And with valproic acid and some of these other anti-kindling medications, we see that the mood episodes get less frequent and less severe over time. So there's a whole bunch of different ways that people look toxic when they're on, if they're on too high of doses of valproic acid. I don't want to read through all of these individually, but you can kind of just see through, like go through the list and see all of these are, you can see that there's a couple of them that are pretty rare, but other than that, they're all kind of like relatively common. But remember that this is just for toxicity. This isn't all of the side effects. If somebody does have toxicity, what do? You stop valproic acid, removed any unabsorbed drug. You can do that with activated charcoal with valproic acid, or whole bowel irrigation. Of course, some supportive care, dialysis. You could consider levocarnitine to reduce levels. Patient counseling points for people on valproic acid. This is another one that you can take with or without food. Any sort of extended release or enteric-coated tablets you want to take whole, don't crush. Educate them on adverse effects to look out for, and educate on the utility of monitoring serum drug levels. So, carbamazepine. So this is another agent that is approved as monotherapy or adjunctive therapy for bipolar affective disorder during manic and mixed episodes. So you'll notice it doesn't say major depressive episodes as one of the FDA-approved indications. Carbamazepine seems to be most useful for treatment resistance or people who don't tolerate the other mood stabilizers. Also for people with bipolar 2 or who have dysphoric mania. So maybe they're manic, but they're not the people who enjoy being manic. They're kind of in those more irritable states as opposed to being like euphoric. Or people who have comorbid substance use disorders. For carbamazepine, it could also be helpful in patients with other neuro conditions. So maybe they have seizures, maybe they have other types of neuropathic pain like trigeminal neuralgia. And so we're kind of getting a little bit more bang for our buck there. The mean onset of efficacy in mania is only about 7 days, so it is pretty rapidly acting. This is another one. You don't need to know the mechanisms of action, just know that it has anti-kindling properties, and that makes it more useful for rapid cycling in mixed states. Patient counseling. If you're giving the immediate release or the suspension, you want to encourage them to take it with food. Swallow extended release tablets whole. Avoid grapefruit products, because this is something that's metabolized through 3A4. It also has a ton of other drug interactions. But grapefruit products will increase carbamazepine levels and could increase the risk of toxicity. Educate on adverse effects, and then review importance of therapeutic drug monitoring. So we have Sam. He's a 34-year-old male who's endured 3 episodes of mania and 4 major depressive episodes within the last 11 months. He's currently admitted to the hospital for a major depressive episode. What is his likely diagnosis? What do we think? What do we know? And then what does that tell us about what we should factor into our assessment? Bipolar 1 with rapid cycling. What tells you that? Yep, so he's had more than 4 episodes within the last 12 months, and he's had mania. So that tells us it's bipolar 1 because he's had mania. And then the episode frequency tells us it's rapid cycling. And then currently he has a major depressive episode. Which of the following would be the most appropriate pharmacotherapy option? Lithium, quetiapine, haloperidol, or divalproex? Okay, so it's kind of a mix between lithium and divalproex. So for everybody who said divalproex, why'd you say that? Not that it's wrong, I just don't know why you said it. It's faster acting. What else about it? He's not suicidal, so maybe you don't need the lithium anti-suicidal effects. Sure. has anti-kindling properties, and what's that useful for? Rapid cycling, exactly. So so people who said lithium, any thoughts as to why lithium might make the most sense? I'm open to suggestions. Okay, so it's not that lithium is totally inappropriate. You probably could start it. It's just that of the options, divalproex is most appropriate because of all those reasons that we just said. Okay, lamotrigine. So lamotrigine has an FDA-approved indication for long-term maintenance of bipolar affective disorder. Notice it doesn't say anything about acute states. So it's most useful in the depressed phase of bipolar affective disorder. You could use it in acute major depressive episodes associated with bipolar disorder, but it doesn't have an FDA-approved indication for those. It might be helpful in patients with comorbid anxiety and reducing some anxiety. It is definitely not helpful in acute mania, ever. So remember that. Don't use lamotrigine for acute manic episodes. There aren't any overt contraindications for lamotrigine, but it does have a very slow onset of action because you have to slowly titrate it because of very high risk for Stevens-Johnson syndrome. And so because of that risk, you have to do a very slow titration, which I think I outlined either here or in the pre-lecture material. Lamotrigine also has anti-kindling properties. It is an anti-epileptic, so this might be able to also be effective for people who have more predominant depression symptoms in their bipolar disorder, but maybe they're also having some sort of rapid cycling or mixed states, maybe with some hypomanic features. So patient counseling is kind of similar to all the other agents. Lamotrigine can be taken with or without food and can be taken morning or evening if only taking it once a day. Always want to warn patients of a possible rash. So this is the big thing that we look out for with lamotrigine, and we tell everybody. If they start seeing any kind of rash at all, immediately stop taking it and call their prescriber. The lamotrigine dose may need to be increased if patient starts an oral contraceptive. So these are just things to consider. Lamotrigine also has quite a few drug interactions, and this is just one of those to consider. So I think that the dosing guideline that I have is in the pre-lecture material, and that tells you also how to adjust the dose too if somebody's on concomitant valproic acid. So then when it comes to antipsychotics, first generation antipsychotics, like I said, we don't tend to use them beyond the acute episode, so we'll just kind of try to get them sleeping, try to get their agitation controlled, and then stop them and switch to a second generation if that's what was needed in the first place. If we started the second generation from the get-go, then we just continue the second generation as long as it worked. So most of them are considered safe and effective for acute mania with or without psychosis and maintenance, even if they're not FDA approved. So there's a few agents that do have FDA approval for various states of bipolar disorder, like acute manic episode, acute depressed episode, whatever. However, you could kind of use any of them. They all kind of work pretty similarly. Dosing regimens for the antipsychotics are the same as for psychotic disorder. So therapeutic, like the kind of therapeutic dosing window that you see for treating psychotic disorders is the same as it is for treating bipolar affective disorder. And then, like we kind of talked about, clozapine is indicated in very severe bipolar affective disorder that is unresponsive to mood stabilizers and other antipsychotics. So there isn't like a clear definition of if you failed 4 things, then you go to clozapine. It's more just like when you really feel like there are no other options, then you try clozapine. So these are just a couple things to consider for each of the individual antipsychotics that we see more commonly used in bipolar disorder. I don't think we need to go through these all one by one. No, okay. Okay. Oh, good, we're at the end. Shoot, then I did end early, and you could have taken a break. Okay, so we have Tim. He's a 56-year-old male with a history of bipolar 1. He's being seen for a psych med management visit. He was living in California for several years and reports doing relatively well, but recently moved back to Boston. With the stress and activity of moving, he quit taking all of his medications, and he's not taken them for at least 2 months. He thinks he's been doing fine, and in fact, he feels better than ever. His primary concern is that he moved in with his cousin, and this hasn't really been going well. They argue all the time. Tim admits this is often due to his, quote, short fuse, which is not normal for him. His cousin is also frustrated because, quote, he says, I never shut up and I keep starting things around the house and never get them finished. He's also mad because I keep going to Mohegan, but I just know I'm going to win big any day. The interview is difficult as Tim is talking incessantly and is difficult to redirect. He is also visibly agitated and moving constantly. So what do you think Tim's most likely diagnosis is? Mania with psychotic features, hypomania, major depressive episode with psychosis, or catatonia? Oh boy. Okay, for everybody who said mania with psychotic features, tell me why. He's been diagnosed with bipolar 1. And he hasn't taken any of his meds, so maybe that triggered a switch. Okay, any other thoughts? What about thoughts about hypomania? What tells you one or the other? He wasn't hospitalized. This is an outpatient visit. What else? There's no psychosis. Because what do we need for psychosis? Hallucinations, delusions, disorganized behavior, disorganized thought. So this actually doesn't have any psychosis. Is there any part of this that's, because I want to make sure that I'm actually making like this really clear. Is there any part of this that looks like psychosis to you guys that we can clarify? Difficult to redirect him. Okay. And the short fuse. So when people hear short fuse, what do you think of? Irritability, right? That's what I think of when I think of short fuse. So irritability, I can be irritable. I've never been psychotic. So that one I don't necessarily think of as psychotic. And then difficult to redirect him could be like disorganized thought or speech. But he tells you this whole story, and you can follow him. He's actually telling a story, and you can like actually follow it. So that tells you that it's not disorganized. It's just that he's talking really fast, and you can't interrupt him, which is more of, it's that rapid speech. But you can still have rapid speech without being psychotic. Does that make sense? Great. Any other thoughts about why this might be a little hard to tell the difference between the two? Okay. So, yes, it's hypomania. So, a different patient with bipolar disorder and suicidality may benefit from which medication? Lamotrigine, valproate, lithium, or carbamazepine? Okay. So almost all of you said lithium, which is the agent that has anti-suicidal properties. And so for the most part, if you see suicidality and you see lithium as an option, it's probably going to be lithium. Or clozapine, one of the two of those things, depending on the situation. Okay. It is determined that it's appropriate to start an antidepressant in a patient with bipolar disorder in an acute major depressive episode. Which agent is the least likely to cause a manic switch? Bupropion, venlafaxine, amitriptyline, or fluoxetine? Nice. Bupropion is the agent that's least likely to cause a manic switch. And why is that? Because it doesn't affect serotonin. Exactly. Okay. So I think that's all those. I know that there's a heavy emphasis on diagnosis that I put in a lot of the questions today. And I know, or at least as I remember from last year, you guys may not be used to a lot of that diagnosis talk. The thing is with psychiatry, and especially when it comes to some of these more, what we call severe mental illness, like psychosis and bipolar disorder, the diagnoses are really important because that tells us what meds to pick. So you have to be able to know that like the symptoms are indicating a certain type of diagnosis, and then let that lead you into the type of medication that you're going to pick. So if you guys have any questions about that stuff, please don't hesitate to keep posting on Blackboard, shoot me emails, come up after class. But thank you. Hi. Yeah, oops, I'm sorry.